Renal trauma refers to injuries to the kidney, often caused by blunt or penetrating trauma. Proper staging and treatment are critical for effective management, as the kidneys are vital organs with rich vascular supply. Below is a detailed discussion of the staging and treatment of renal trauma. Staging of renal trauma. Renal trauma is classified based on the American Association for the Surgery of Trauma, AAST, renal injury grading system, which categorizes injuries from grade 1 minor to grade 5 severe. AAST renal injury grading system. 1. Grade 1 minor. Characteristics: subcapsular hematoma or non-expanding hematoma, microscopic hematuria without significant parenchymal laceration, no urine extravasation. Imaging: appears normal or with minor findings on CT. 2. Grade 2 minor. Characteristics: non-expanding perirenal hematoma, small cortical laceration 1 cm depth without urinary extravasation. 3. Grade 3 moderate. Characteristics: laceration 1 cm into renal cortex without extending to the collecting system. 4. Grade 4 severe. Characteristics: lacerations involving the collecting system leading to urine extravasation. Injury to renal vasculature, segmental artery or vein. Perirenal hematoma may extend significantly. 5. Grade VI, critical. Characteristics: shattered kidney or avulsion of the renal hilum leading to devascularization. Severe renal artery or vein injury. Diagnosis: history and physical examination. Mechanism of injury: blunt versus penetrating, associated injuries, and hematuria. Laboratory tests: urinalysis for hematuria, serum creatinine for renal function. Imaging: CT scan, gold standard. Contrast-enhanced CT provides detailed anatomy, identifies active bleeding, urine extravasation, and associated injuries. Ultrasound, fast, limited use in stable patients, more for detecting large hematomas in unstable patients. Angiography, used for vascular injuries and interventional embolization. Treatment of renal trauma. Treatment depends on the grade of the injury, hemodynamic stability, and presence of other injuries. It is divided into non-operative management, NOM, and surgical intervention. Non-operative management, preferred for stable patients, especially in grades 3 injuries. Components include observation, monitor vitals, urine output, and hemoglobin. Bed rest until hematuria resolves. Fluids and analgesia, maintain hydration and pain control. Antibiotics for injuries with urine extravasation to prevent infection. Serial imaging, follow-up imaging to assess resolution. Interventional radiology. Angioembolization, effective for hemostasis in selective arterial bleeding or pseudoaneurysms in grades 3-4 injuries. Surgical management, indicated for severe injuries, grades 4V, or unstable patients. 1. Nephrectomy, indicated for grade V injuries with shattered kidney or vascular avulsion when kidney preservation is not possible. 2. Rhinorrhaphy, repair of lacerations and collecting system injuries. 3. Urine diversion, placement of a ureteral stent or nephrostomy tube for urinary extravasation. 4. Vascular repair, reanastomosis or repair of renal vessels. Special considerations: pediatric patients, typically managed non-operatively when possible due to higher renal reserve and better healing potential. Penetrating trauma, higher likelihood of surgical intervention due to complex injuries. Complications: 1. Acute, hemorrhage, urinary extravasation and infection. Shock. 2. Chronic, hypertension, renal artery stenosis or ischemia, renal insufficiency or loss, perinephric abscess. Prognosis: most minor and moderate injuries, grades 3, resolve with conservative management. Severe injuries, grades 4A, may require surgery and are associated with higher morbidity. Timely diagnosis and treatment improve overall outcomes. Management decisions in renal trauma should balance the need to preserve renal function with the urgency to control life-threatening conditions. Multidisciplinary collaboration, urology, trauma surgery, interventional radiology is essential for optimal outcomes.